All right, so welcome to our March Comprehensive CDI Apprenticeship free webinar series, Navigating Your CDI Journey. I'm Dr. Aziz. I'll be guiding us through this discussion today on chart review techniques for hematological diseases. It's a pleasure to join you here today. We are a few months in now to the year, and we're going to continue to offer these navigation type of webinars with the intent of helping you with deciding if CDI is a field you're interested in and also if CDI is something that you feel you could master. If you're already in the CDI profession and you're seeking to simply improve your skill set, you're also in the right place. Today I'm working on just a laptop computer, so I don't have as good of a view of the chat box as I normally would. Any of you who are in attendance and would like to comment, please feel free to take the microphone and share anything you'd like to. If there's any first-time attendees, as well as any repeat attendees for that matter, feel free to take a moment now to come on the microphone if you would and introduce yourselves. Let's know who you are and where you're connecting from.
Hi, it's Colleen Roth. I was on the first one, and unfortunately, the last one, for whatever reason, I thought was Thursday night instead of Wednesday night. So I missed that one.
That's okay, Colleen. We have everything recorded, so if you'd like to access the recording, you just send us an email.
I think I got the email with the recordings on it. So,
Great.
but thank you.
Very good. Welcome. Nice to see you again today. Anyone else like to introduce or share anything before we get started? Not obligated to, obviously, but okay. In that case, we'll go ahead and get started then. So, hematological diseases can sometimes be a challenge depending on your comfort level with the subject matter. The goal, of course, in CDI, when it comes to any organ system or set of disease processes, including hematology, is to make sure that we align the evidence that's available to us through the electronic health record alongside the documented provider assessments to see if there's any need for a provider query, clarification query, so that we can get the most specific medical record possible. You don't have to be an expert in hematology to achieve that process, but there are some basics that you must know. If at the end of this discussion today, you feel like you could use more of a review of hematology than time allowed for today, by all means, feel free to send us an email and we can send out a study guide for you to work with to help you get a little bit more familiarized with which parts of hematology you should know a little bit better than others to focus on for your preparation. So today we will begin then by reviewing the common hematological conditions you're likely to encounter and also their key clinical indicators. We are going to identify risk factors and key treatments that can be documented in the medical record to give you an idea that something hematological may need attention. We will look at best practices for validating hematologic diagnoses and treatments through the chart review process. And finally, we'll discuss the importance of precise and thorough provider documentation in hematology cases with the perspective of hospital inpatient metric impacts. All right. So getting started then, you should know the basic cell types before you begin to try and review charts that feature hematological diagnoses. It's very important at first to make sure that you feel comfortable with all of the different types of cells that you might find within the blood system. So red blood cells, white blood cells, and platelets. And because we do have diseases that affect the clotting cascade, coagulation, and questions about bleeding as well to be considered in our chart review process, you should also consider your ongoing knowledge of the intrinsic and extrinsic clotting cascades, as well as how the primary platelet plug is formed for initial hemostasis. Why does hematology matter in particular for CDI specialists? Well, part of it is that these conditions can be complicated, and the more complex they are, the more providers need to incorporate clinical indicators into their assessments to help ensure the right ICD-10 codes are picked up by CDI encoding. As such, and because providers don't always do the best job with providing such indicators, we're at frequent risk of either under or over coding, uh, depending on how complete that documentation is, and how accurate it might be. That accuracy, of course, impacts a lot more than simply reimbursement. It has many hematological diagnoses do have the opportunity to affect reimbursement, but several also impact quality metrics, metrics such as expected mortality in the risk adjusted mortality index in that denominator of that index, as well as risk of readmission and reasons for prolonged length of stay as an inpatient. So clearly very important types of diagnoses can arise. Some of them are quite impactful to the record. If you consider the global list of diagnoses that you're likely to consider then that are hematological in nature, you should think about anemias of all varieties, including iron deficiency anemias, hemolytic anemias, aplastic anemias, and anemia of chronic disease. And it should be in the forefront of your mind to consider the risk factors. Iron deficiency anemia, quite common with chronic GI or genitourinary blood loss. Hemolytic anemias can arise from a host of different conditions, including notoriously on exam questions, the glucose 6-phosphate dehydrogenase or G6PD deficient patient who then eats some type of food or consumes some other medication that triggers that hemolytic event. And some of us have autoimmune hemolytic anemias with different types of antibodies that can trigger that as well. Aplastic anemia is a disease that is associated with different causes as well. Notoriously, certain viruses are known to cause aplastic anemia, and there are some agents of some chemotherapeutic agents, for example, or antimicrobials that can also cause it. And then there's the anemia of chronic disease. Can anybody name a few chronic diseases or maybe share in the chat box a few chronic diseases that
Uh,
they're familiar
ki-
with that can cause an anemia?
Kidney disease.
Yeah, very good. Kidney disease is one. Colleen, you're correct. Welcome as well to you, Alicia. Nice to see you joining us this evening. Um, yeah, which stage of CKD do we typically start to see the anemia of chronic disease, Colleen?
I don't know, but I would guess somewhere around 3.
Yeah, once you start getting into the stage 3 and higher, stage 4, stage 5 for sure, you have a chance of that anemia of chronic disease. And does anybody recall why patients who have advanced chronic kidney disease may develop an anemia?
It's got to be something to do with filtration or
Yeah, the filtration from of the uh, I can't think of into your blood.
Okay, so glomerular filtration can be affected over time, but that really leads to decreased urine output and a whole host of electrolyte disturbances and a lack of responsiveness to certain hormones like parathyroid hormone and others. Remember also that the kidney makes some hormones. It fully activates vitamin D into its D3 form. The D3 form is the active form of vitamin D that the kidney is involved in activating. But in the world of anemia, we should be thinking of a whole different hormone. Who can remember the name of the hormone made by the kidney that stimulates red blood cell production?
Erythropoietin. I just now looked it up. It's erythropoietin. Erythropoietin.
Very good. Erythropoietin, or abbreviated EPO, because nobody likes to keep saying erythropoietin over and over again. So EPO for short. And this uh, aging, chronically diseased kidney then may not make sufficient EPO to help us sustain the approximately 13 to 15 grams per deciliter of hemoglobin we hope to see. What about some other causes of anemia of chronic disease besides kidney disease? Commonly occurring ones.
In pregnancy?
Well, you could see an anemia of pregnancy, but we have to be careful there because pregnancy is considered a normal physiological state rather than a disease state, although there are diseases that are featured in pregnancy as well. And maybe perhaps that's what you're referring to there.
I
What
think
else?
um cancer related anemia
Good.
and
Yes.
chemotherapy related both.
Very good. Yes. So chemotherapy in and of itself, that has a different code.
Right.
When anemia is a consequence of chemotherapeutics, we have one way of coding that versus anemia that's from the disease itself, the disease process itself. So very good. I appreciate that conversation around anemias of chronic disease. Why do we mention this? This is not a review of a school or a basic science study, but you need to know the context in which, as you review charts, these details might come up. So it'd be very important for you to know the different causes of anemias. Similarly, when we look at coagulopathies, these are bleeding disorders. So hemophilia, von Willebrand's disease, these are common causes of bleeding. Von Willebrand's is most common cause in terms of a coagulopathy you may encounter. So clotting factor deficiencies in general can lead us to bleed. Most of these are inheritable disorders, and so looking at the family history becomes particularly important. We can also develop coagulopathy sometimes as a result of infection. For example, those who suffer with meningococcemia from the organism Neisseria meningitis may develop a gram-negative form of disseminated intravascular coagulation, which is a consumptive coagulopathy where all of the factors are in fact consumed. So coagulopathies are important, whether they're genetic or inheritable in nature. You need to know something about them. Why? Not because it's school, not because it's that type of a test, but simply because you need to think about as you open each case, could this come up for this patient? What am I reading in the past medical history? What am I reading in the active problem list? All right. Then we have thrombotic disorders, such as we see the story of deep venous thrombosis, commonly in the lower extremities with resultant pulmonary embolism. But we know, again, there's a whole host of risk factors for developing blood clots, for developing thrombi. Does anybody know any of those?
Stroke or CVA.
Yeah. So having the immobilization, for example, is that what you're thinking of there? The
Yes.
immobilization associated with having a CVA with perhaps a hemiplegia that
Well, you can dislodge um, a clot and it go into like your main neck artery or something like that,
you
and then it'll
could.
cause.
You could. So you're talking about a clinical consequence of
Mhm.
thrombosis in this case, which is also worth talking about because if you think a patient's had a stroke and they're not properly documenting it as such, that's an important related concept to mention. What about causes of thrombotic disorders? We also have inheritable causes and we have secondary
vein
causes.
vein insufficiency.
Yeah. What's insufficient about the veins are those one-way valves, correct? So those one-way valves and the little muscles on either side of the veins that are meant to promote movement back to the heart can become insufficient. That can then lead to stasis of blood, which is consistent with thrombosis. Also injury to the lower extremities can leave a person prone to deep vein thrombosis. What about lifestyle choices? Are there any lifestyle choices that can make a person more prone to DVT and PE?
Sedentary, or if you travel a lot, if you're in a plane or car a lot.
Very good. Yeah, long haul
Obesity.
travel. Good. Sorry, I talked over you.
Obesity.
Yeah, the supramorbid and morbid obesity, were meant to use terms like class 3 obesity now. I think more so than the mild, moderate, severe, or morbid type of
And
language.
also smoking.
Very good.
Hmm.
Smoking cigarettes, particularly if a person also takes oral contraceptive tablets.
Right.
There's a particular association between smoking cigarettes and taking oral contraceptive tablets and a prothrombotic state developing. We can also mention cancer here, particularly metastatic cancer that can lead to certain hypercoagulability disorders. And what about the inheritable ones? So you've done a great job with the lifestyle and secondary causes. Anyone remember a few conditions that when you have them from a genetic inheritance basis, you're more likely to clot?
Well, I was going to say von Willebrand's is not clotting.
Yeah, von Willebrand's, we saw that in the second bullet point there with coagulopathies for a bleeding disorder. So what are some other genetic problems that you might remember affect this system? Do you remember the factor V Leiden mutation, for example?
Yes.
Okay.
So, yeah, think about those ones. And protein C and protein S deficiency, uh, or also antithrombin 3 deficiency. Those are all common genetic causes. So if you read that in the record, in the past medical history, you should expect to see potentially clinical indicators that include these comorbidities like thrombotic disorders. And it's important to evaluate provider assessment documentation to see if they've actually included those or not uh, in their write-ups. We also have all of the vast number of lymphoproliferative disorders and myeloproliferative disorders like leukemias, lymphomas, and multiple myeloma or B cell dyscrasia to consider. And those are too numerous to get into in tonight's brief session, but still we can talk about each of those individually as we move forward. And then the platelet disorders to round out the list. So platelet disorders, it matters which type. Is this an ITP, immune thrombocytopenic disease, or is this a TTP, a thrombotic thrombocytopenic purpural disease? Or yet again, do we have HIT, heparin-induced thrombocytopenia, which some people develop? Also, platelet disorders, particularly thrombocytopenia, can arise as part of pancytopenia when all three cell lines are down in number below normal, typically due to one unifying etiology, like chemotherapy or like a myelosuppressive disorder of the bone marrow. So many conditions that we can consider here tonight. The idea here is not to make you dive too deep into any one of these subjects particularly, but rather to remind you of the broad nature of hematology and all the different nooks and crannies of the discipline that you may have to jump back into in the textbooks ever so briefly, just so you can become confident as you prepare queries based on your observations. Again, providers tend to document in their assessments only part of the story. They may either leave out certain diagnoses in their assessments and plans, or they use other terms which they think might be equivalent terms, but are in fact not equivalent to the disease of interest. All right, so let's take a look at some of these risk factors. And we've just talked about family history of hematological diseases. We've talked about CKD. We didn't mention chronic inflammatory conditions, but many of those chronic inflammatory conditions, of course, can be associated with the anemia of chronic disease, as can several autoimmune disorders. We then have recent surgeries and hospitalizations. This was also mentioned about being immobilized for prolonged periods of time, whether it's from having a very high BMI or because of incapacitation from a surgical procedure, for example. And some medications also carry a risk of interfering with the blood clotting and then also the appropriate removal of those clots. Remember that we have our own natural clot busting protein called plasmin. Plasmin can be released at any time that clots are found to be excessive. And if your own plasmin system is not working, we can, of course, consider using tissue plasminogen activator or TPA, which is a recombinant product that can be administered to break up clots, depending if you use them on the right timeline. So, indicators in the chart, of course, we want to look at those complete blood counts, including all the differentials. You want to know what the relative proportion of the white cells are. Also, the differential is useful for telling us about immature cell types, like bands, bandemia that we can see with white cells being pushed out too soon due to profound infection into the circulation. And also, we may see nucleated red blood cells. We really shouldn't see nucleated or immature red blood cells that still have a nucleus out in the circulation unless we're really trying to make up for a pretty profound loss of hemoglobin. And of course, the coag profiles are also valuable for us to look at, the prothrombin time or PT and the activated partial thromboplastin time or PTT. And remember that the PT can be standardized because there are so many different ways of measuring the PT out there. We have a unit of standardization in the International Normalized Ratio, or INR, that can be useful as well to determine if coag profile may be out of balance. Clinically, you might see unexplained bruising, bleeding episodes, or even thromboses. There can be low levels of energy because of poor oxygen delivery. The skin can appear pale. If you have anemias that feature a lot of hemolysis and breakdown, remember that patient can become jaundiced due to an excess of bilirubin. You can eventually exceed the conjugation system to make bilirubin water soluble. And then finally, enlarged lymph nodes, splenomegaly for certain conditions, malignancies. We want to keep an eye on the record for any, oftentimes, radiological evidence of lymph node enlargement, lymphadenopathy, or splenomegaly that may be uncommented upon in the provider documentation. Medication-wise, what might you raise an eyebrow to wonder? It's not uncommon to look at your medication administration record or MAR and see that a medication has been prescribed and you wonder, why is there no matching diagnosis for this medication? And you can kind of backtrack through the record and understand, okay, they're treating XYZ disease because I see heparin on board or warfarin or one of the more modern blood thinners like Xarelto and some of the others that are factor 10A inhibitors. You also see plenty of use of immunosuppressants and steroids, particularly when the anemia is autoimmune in nature. And we do also see, for some blood cancers, very targeted and specific types of chemo that can let us know the patient may have leukemia or lymphoma. And there again, because ICD-10 allows for such a diverse number of diagnoses, we'd hope that the etiology would be clarified, the acuity and type very specifically. We want to know, is it acute or chronic leukemia? And is it lymphocytic or myelocytic in nature? To begin to decide what other comorbidities may or may not be present. The procedural interventions, of course, you might see transfusions of red cells for anemia. You may see platelet transfusions, cryoprecipitate transfusions, stem cells if the bone marrow has been wiped, you might see stem cell transplantation. And in some cases, if the spleen is too aggressively removing cells from the circulation, even a splenectomy might be indicated, although that's hopefully less common today than in the past, uh, with the number of other means we have to treat these conditions today.
What
Supportive wise, oh, go ahead, please, with your
what
question.
about apheresis where they have too much blood products or something and they cycle it out? Is that
Yeah, that's also an important type of intervention to look out for. And again, the key there when you identify any procedure like that is go back and look at the assessments and plans. It's not good enough for proper coding and billing and metric and risk adjustment and quality scoring, all those different things that we worry about. It's not enough just to ramble on about those topics in the subjective portion of the notes. Providers are meant to give in their assessment and plan a specific diagnosis with the additional comments on risk factors, clinical indicators, and treatments that endorse that diagnosis. And we know for some providers, they just give a one-line commentary. So yes, absolutely, any kind of pheresis treatments should be considered uh, in the setting of the provider documentation and what is the importance and relevance of it. Intravenous immunoglobulins are given for certain autoimmune conditions as well, so that can be a trigger to consider why that's being administered. And also there are a number of prophylactic antibiotic regimens when the absolute neutrophil count starts to drop to a lower number so that we help prevent certain particularly life-threatening bacterial and other infection. We really want the provider then, as mentioned in the last slide, to encourage providers to link treatments to diagnoses. So if they're taking any of these, uh, it's particularly important to make sure that that is accounted for. The lab values also matter. So sometimes a provider will pick up a diagnosis from the emergency room documentation where things were largely speculative at first, or even from the HMP author where the initial assessment and plan is quite a broad one as well. But over time, you may see copy paste forward entries into the medical record that really don't line up well with the lab trending. So a good example would be something like acute blood loss anemia. It may seem like a patient has acute blood loss anemia from the story and from the measured hemoglobin to that point in the story, but suddenly somebody will come along on day 2 or day 3 and say, well, this patient has a known low hemoglobin level that they live with for various reasons. And so while this hemoglobin looks low, it's actually only about a half a gram to a gram below the patient's normal baseline. So it's important to always contextualize the lab results and don't just assume that they endorse a particular disease just because you've seen one abnormal value. You want to see more than one. The physical exam and clinical findings are also important to consider. So if the patient has pallor or petechiae, purpura, lymphadenopathy, as mentioned, we want to know where are the orders that explain the workup for this, and where are the diagnoses that match these signs and symptoms. Remember, in coding and in CDI work, we're not interested in signs and symptoms being coded when a viable diagnosis exists to explain those signs and symptoms. So just like we'd rather see uh, atherosclerotic heart disease leading to a type 2 myocardial infarction than to just see chest pain or angina or acute coronary syndrome, all of which are pretty useless. Similarly here, telling us you have a low hemoglobin, a patient, or that a patient has a low hemoglobin when you look at their uh, provider assessments, that's not very good documentation. Low hemoglobin could occur from a number of processes and might even result from hemodilution, from aggressive IV hydration. So we're not interested in lab values or symptoms to get the best metrics. We'd like to see definitive diagnoses that explain those signs and symptoms. We've talked a little bit already about the orders you might see. And really, the problem list doesn't always match the daily progress note assessments. And so many times we know that problem lists are a problem because you don't know what's an outdated or historical diagnosis and what is an actively treated diagnosis. Classic example is a patient who has a primary cancer of some sort that's unfortunately become metastatic and the disease has spread to other organs. And at some point, the patient has a surgery that removes the organ where the primary disease was held. And yet we still see cancer of that organ, not as a Z code, as a historical code, but rather as an active code, as if that organ were still to be there. So we really have to make sure that the problem list is updated as well, or at a minimum, there are no overt conflicts with the assessment portion of the note. Again, I've passed reference to these already a little earlier, but just to mention that we should always be looking out for discrepancies between lab values and assessments or diagnostic statements. What about the inverse situation? You've made a claim for an acute blood loss anemia, to use my other example, but hey, the hemoglobin's not so low. Doesn't seem to be much lower than their baseline. And it does not seem to have dropped acutely. So why is that there? We may need to pose a clinical validation query to make sure that that diagnosis really is fortified with additional clinical indicators to support it. And also treatment that started without a good, clear idea as to why. You might be able to infer why that is. If for example, if a patient has pneumonia and they've been treated with I think we hear some background noise here. I'm just going to ask that you mute your microphones if you don't have a question or a comment. Imagine you have pneumonia on board for a patient admission and you see a switch in the category of antibiotic from something that covers gram-positive organisms to something that more aggressively covers gram-negative organisms or anaerobic bacteria or what have you. You'd want to understand why that is. I mean, it's pretty obvious that the person has decided they're treating something besides a regular old strep pneumonia and maybe dealing with a more exotic cause of that pneumonia. But that doesn't mean that we can imply it and code it. So be wary of treatments that are initiated and there's no diagnosis to go with it in the assessment and plan section. So we might, for example, formulate a query question. They should be concise and non-leading in nature. Here's an example. Please further specify the anemia, given the clinical indicators noted above from the recent CBCs and differentials. That's very different than saying, are you treating hemolytic anemia? Dear doctor, are you treating a vitamin B12 deficiency anemia? Because after all, look how big those cells are. We know that macrocytosis or large red blood cells can accompany a B12 deficient state, for example. You're not meant to put your own medical knowledge into the query process. Ask neutral questions based on the indicators provided. We'll have a different session at some point on query formulation. So we're looking for these providers to be real specific. Type of anemia, is it iron deficient or anemia of chronic disease, for example? What's the type of coagulopathy on board? Is it a inheritable factor deficiency, or was this acquired secondary to something else? If there's a malignancy, document its impact to the body and as well as to the lab values. If there are genetic markers of the leukemias, for example, like the Philadelphia chromosome or any of the others, they need to be mentioned in the assessment and plan. It's important also that we distinguish acute from chronic because the impact is quite different. Acute blood loss anemia has a markedly different impact on risk adjustment and reimbursement than does chronic blood loss anemia, and yet oftentimes we don't get the acuity properly defined. We'd want to also know if there's any other organs secondarily dysfunctioning that could explain some of these. Bone marrow failure, CKD that we mentioned earlier, infection as a driver of platelet dropping. We know that thrombocytopenia can commonly accompany sepsis, for example. And then have you then captured enough of the comorbidities that matter to truly reflect this patient's actual SOI and ROM, or severity of illness and risk of mortality? There are several conditions, which again, we're happy to send out to any of you who would like to learn more about this, if you don't already know. Acute blood loss anemia is the first condition that we really want to take a deeper dive into with CDI work. And it's a hard one because there's no set amount of hemoglobin that has to drop. Years ago, we used to say you should lose more than at least 2, if not a little more than 2 grams per deciliter of hemoglobin in a 48-hour period, but that's no longer the case. It all becomes more relative. So much more important to negotiate a percent drop from baseline. Most providers are comfortable if the patient has dropped acutely in just a 1 to 2 day period, 15, 20% of their hemoglobin, so they're down to 80% or so of their baseline value rather quickly. That's much more valuable than talking about an exact number because, again, we all live at slightly different baseline hemoglobin levels. The etiology is obviously important. If you're going to claim an acute blood loss anemia, you should have an obvious sort of source of acute blood loss. Otherwise, it's very hard to justify such a diagnosis. The abbreviations are a problem too. ABLA is a well-known abbreviation, but the provider is expected to spell the condition out in its entirety at least one time. Also, in surgical settings, many providers think that having an acute blood loss anemia is automatically viewed as a complication, but it's in fact not always a complication. Sometimes acute blood loss anemia may be an expected outcome, and providers should really consider that rather than writing things like, well, I use a cell saver for my cabbage procedures, so the EBL is 0, the estimated blood loss is 0. We know that's not realistic. Patients who have extensive cardiothoracic surgery are expected to have some post-operative oozing of blood, even long after the sternum is sealed back together with wires and things like that. So it's a matter of letting providers know if a surgical procedure is particularly vascular and it's known to drop the hemoglobin, simply write acute blood loss anemia, comma, expected. It's enough. If it's truly a clinical setting where it is expected, there will be no consequences for the provider. You may be sure to know that even with that 15 to 20% drop in hemoglobin, we are not meant to ask providers about acute blood loss anemia unless there's evidence as such. So do they truly have some of the symptoms that we see, signs and symptoms that we see listed in these open circle bullets? The tachycardia, tachypnea, pallor, hypotension, any AKI as a result of insufficient blood circulation. And with intraperitoneal or retroperitoneal bleeding, you might see ecchymoses or bruise-type lesions around the flanks and the umbilical region. Another common misconception with something like acute blood loss anemia, for example, is that the patient has to have had a transfusion to pick up that diagnosis. And we know, in fact, no. Simply giving supplemental oxygen and monitoring those vital signs and that H&H, hemoglobin and hematocrit, more closely than you normally would represents a form of monitoring that can be constituted as a treatment of sorts to justify your inquiry to the provider. So beware, acute blood loss anemia is a common denied diagnosis, commonly denied diagnosis, and auditors will have a field day taking away the impact of the record by saying this appears to be more of a chronic blood loss than an acute blood loss. So that's why we want the provider to always give us that good justification for their diagnosis. With thrombocytopenia, we have a little bit more of a concern here. We want to know what is the etiology of the thrombocytopenia, because after all, thrombocytopenia is just a lab value in and of itself. Until you know why the platelet count is low, it's not of any particular value. And as mentioned before, it's commonly associated with sepsis. So one great way to clinically validate sepsis, which is constantly under scrutiny by payers, is to look at the presenting thrombocytopenia that now starts to resolve as the treatment of the source infection of sepsis is addressed. This is very, very valuable, both for the thrombocytopenia diagnosis and for the sepsis diagnosis if you link the two of them. So keep it in mind. We generally want to see that the platelet count returns above 150, the bottom limit of normal, before attributing that. Now you can see how complicated thrombocytopenia can get because you have both primary and secondary thrombocytopenias possible within the code set. And furthermore, there are some rare disorders. So if you run into some of these rare disorders as you read through hematological admissions and you don't know what they are, use your local friendly software, coding software, CDI software, or there are a number of online resources, including cms.gov, which can give you all of the details on these conditions. But most everyone likes to rely on their coding and CDI software pop-up tools that can give you the same information. You can see here, Evans syndrome is a rare chronic relapsing autoimmune disorder that we don't know really the whole story as to how it even comes about. But there's typically an ITP along with an autoimmune hemolytic anemia. You can see it groups to the DRG 813 when it's the PDX or principal diagnosis. And if that's not enough, you can dive in deeper. A great source of knowledge is the National Institutes of Health National Library of Medicine series, known as STAT Pearls. STAT Pearls can give you any number of great 2 to 3 page articles that you can learn everything you'd ever want to know and then some about any given condition. So doing well in CDI chart review, particularly for more complicated diseases like the hematological ones, really relies upon a little bit of self-study at first, especially if you know that that's an area that you need to sharpen your knowledge or revisit certain areas that have been a few years since you've studied them. Thrombocytopenia is commonly a denied diagnosis as well whenever it doesn't seem to be clinically significant. So if you haven't done anything for the thrombocytopenia and it sort of just drops a little bit and then returns to normal in terms of the platelet count trend, that's not of any great value. And we cannot get anything out of low platelet count or a downward arrow with platelets or downward arrow PLT or any other euphemisms for thrombocytopenia like a blood cell dyscrasia or a coagulopathy, because those are too broad and we don't really know what the provider means when they say something like that. You can see why it's such an important condition to capture. We only have to look as far back as 4 or 5 years to the COVID pandemic. And so many studies have been done since those COVID hospitalizations. There was a meta-analysis done of 24 recent studies that showed a disproportionately high thrombocytopenia prevalence. of 12% in the population with COVID. That's a very, very large amount, and explains some of the tendencies towards blood clots associated with that condition. Higher rates of ICU admission for management of acute respiratory distress syndrome, or ARDS, when thrombocytopenia is on board. And also there's an increased overall mortality for COVID with thrombocytopenia. So just one disease state like COVID-19 infection raises the suspicion about thrombocytopenia, and most importantly, how was it documented? And was it linked to anything or not? The same can be said for pancytopenia. Pancytopenia is a condition where all three cell lines are low, but it's not enough just to write anemia, thrombocytopenia, and neutropenia. To describe that, you need to use the term pancytopenia for full impact, and very specifically call out the etiology that's suspected to connect the three cell lines being low. So that's about what we have time for in terms of material presentation tonight. I do want to stress that we'll continue to go over different subjects like these. At the end of next month, we'll discuss in a similar way the renal diseases like acute kidney injury, acute tubular necrosis, chronic kidney disease, and end-stage renal disease, as well as a few others to do with the kidney tubular system like nephrolithiasis. And as part of our CCDS exam prep webinar series, also free to attend, on the 15th of April, common challenges on the path to CCDS certification. Really, why do people not pass that exam on the first time? Or why do they find the preparation for it so overwhelming at times? There's usually some simple changes to how you're approaching the test questions, for example, that can really help there. Evaluating provider assessments, where we look at faulty provider documentation and try to see how it might be corrected by way of query process. April 22nd for respiratory diseases and May 20th for neurological diseases. As mentioned in all of our presentations here towards the end, we do have courses as well available. We have a CCDS exam prep class starting April 7th, and another one on May 5th will begin. We have the CCDS exam prep as a self-paced option, as well as a mock exam that's available anytime for you to take. So I will just leave it to you now for any questions you might have about this subject. And I'm open for discussion on anything that we've shared. We can go back and look at prior slides, anything at all that you'd like to do. No comments from anybody this evening? Certainly happy to answer your questions.
I know this course is very helpful.
I'm so glad that you think so, and you find it to be helpful. Thank you for saying it. And we do aim to empower those who feel like they can't necessarily get their mind around a complicated subject like hematology to feel like, yes, there's a logic and a number of steps involved that you could in fact master the topic just fine.